Now, it's my pleasure to present Dr. Adam Weir, our deputy head of our groin pain center in Aspetar, who has a PhD in groin pain, been working with us 3 years, and he'll tell us something about anatomy and terminology in groin pain.
Okay. Is it working okay, the microphone? In the back? Yeah, thanks a lot. Back again. For those who were here for the muscle session, apologies to have to listen to me again. I'm excited to do this talk to you, for you today on groin anatomy and on terminology. Over the next 15 minutes, we'll have a quick refresher on the anatomy of the groin region. I'll focus in on the pubic symphysis, inguinal canal, and the adductors. And the second half of the talk will be an update on the terminology in groin pain. So if we start focusing in on the groin anatomy, it seems a very British thing to do. But we start at the pubic symphyseal joint, at the front of the pelvis. Some specific landmarks, the inguinal ligament. You can palpate the insertion at the pubic tubercle and the pubic crest. If we look at the joint axially, we see that within the joint there's a fibrocartilaginous disc with a median cleft which can best be seen posteriorly, and at the ends of the bone are coated with hyaline cartilage. Around the joint is a capsule. That capsule is thickened superiorly and inferiorly, the superior or lacunar ligament and the arcuate or inferior pubic ligament. We saw the pubic tubercle here being at the end of the inguinal ligament, and if we follow that up, the inguinal ligament here runs up to the anterior superior iliac spine. If we move up above the inguinal ligament to the region of the inguinal canal, then we can see the different layers. If we look in the top right here of the abdominal wall, the external oblique, the internal oblique, and the transversus abdominis, forming the 3 layers. And here, the sperm duct and the vessels and the nerves coming in, entering into the inguinal canal, running through the 3 different layers, and then exiting here at the superficial or the external inguinal ring. And here we can see that very nicely if the cord is removed. And just to focus in again here, so transversus, internal and external oblique, and here then the inguinal canal. The region where the transversus and the internal oblique fuse behind the external ring here, this is called the conjoint tendon. Time to shift our focus down towards the adductors. Here we see the pubic symphysis and the adductor longus, left and right. We can see here the proximal tendon, and the proximal tendon here diving down into the muscle. What's interesting is if we flip, so you imagine we're going to take the muscle and flip it back upwards, and look at the posterior side here, at the proximal attachment, it's muscular. So only 40% of the proximal insertion is actually tendinous, 60% is muscular. And what I also find really interesting is that the adductors and the abdomen are fused. So if we follow the adductors coming up, the adductor longus, it's passing in front of the pubic symphysis and is continuous with the rectus abdominis. And this structure here in front of the pubic symphysis also sends fibers directly into the joint. This has a number of names. I'll call it the pre-symphyseal aponeurosis, but there's a lot of terms going around for this. Here's a beautiful dissection from Sydney, Australia, where you can see very nicely here on a fresh cadaver how the adductor longus crosses and merges with the right external oblique, and here it's passing underneath and merging with the left external oblique. And if we zoom in on that here, we'll take with the forceps and bring that back. So we bring that down, and here we can see that very nicely how continuous, and that this wide structure in the front here is this aponeurosis or plate in front of the pubic bone. So now we've got the anatomy refreshed. We think this is all new, but actually this beautiful drawing from Eisler is more than 100 years old, and I think they show us beautifully there with a pencil sketch how complicated the anatomy can be. The second half of the talk is about terminology. In November, we had 4 great days here in Aspetar with the first World Conference of Groin Pain on Athletes from the 1st to the 3rd of November. And on the 4th of November, we had an extra day to have an international agreement meeting on the terminology and definitions of groin pain in athletes. It was a fantastic day, and we reached a unanimous consensus on the terminology that we can use. The names of the members are all in the handouts that you have. 7 sport physicians, 6 physiotherapists, 5 general surgeons, 5 orthopedic surgeons, and a radiologist in a pear tree. And it's a Handball conference today, but what's obvious is that most of them, I think, actually come from footballing backgrounds, and you can spot the ones by the way they're standing here in the wall as we prepared for the day. During the day, we agreed that we would define a number of specific recognizable clinical entities: adductor-related, iliopsoas-related, inguinal-related, and pubic-related groin pain. And during the second half of the talk, I'll run through those with you. We were also in agreement that we should never forget the hip as being a possible cause of groin pain, and then the big list of other causes. So if we look at these specific defined entities, there's some considerations before I present them to you. The majority of the work and knowledge in the field of groin pain scientifically comes from long-standing injuries. There's actually very little data on acute injuries. We felt that this classification system probably would be fine to use in acute injuries, but there's so little data out there. You'll see it's a clinically based system, so you need history and physical examination to classify athletes into having these different entities. It's perhaps self-explanatory, but they must feel the pain in the affected region. So like the first case, he's having pain in the adductors. That will bring us towards adductor-related. And we, as a group, didn't have the time to go into exact examination techniques. So what I'll present to you today is the way that I do it in clinical practice, and that's based on the techniques described by Per Holmick in a paper in 2004. He's the head of our groin pain center, and the article with the techniques is also in your handout. So if we move to the first specific defined clinical entity, that's adductor-related groin pain. To classify an athlete as having adductor-related groin pain, we should have local tenderness of the adductors, so you can put your finger on the proximal tendon, and the athlete should recognize this as being their injury pain, and you should be able to provoke the recognizable injury pain on doing resisted adduction testing. The second entity that we defined was iliopsoas-related groin pain. To classify an athlete as having iliopsoas-related groin pain, there should be local tenderness of the iliopsoas. That could be either at the distal tendon and the insertion on the trochanter minor, as we can see here, top right, or within the abdominal portion of the psoas. If you get them to relax the abdomen and then they can raise the leg here, the psoas will become stiff and you can palpate that through the abdominal wall. And this entity is more likely if there's pain on resisted hip flexion testing or pain on iliopsoas stretching, as demonstrated here by Professor Holmick. The third entity, inguinal-related groin pain. To classify an athlete as having this, the pain should be felt in the inguinal canal region above the inguinal ligament. There should be tenderness in the inguinal canal. There shouldn't be a palpable inguinal hernia. Otherwise, they just have an inguinal hernia and don't have inguinal-related groin pain. And this entity is more likely if there's pain in the inguinal region on performing Valsalva maneuver, coughing or sneezing, or pain during resisted abdominal muscle testing, as demonstrated here, bottom right. The last specific defined clinical entity that we discussed was pubic-related groin pain. For this to be present, there must be tenderness of the pubic symphysis or the immediately adjacent bone. We can palpate that here from superior. Put your finger on and run down the front of the pubic symphyseal joint. And as a group, we couldn't agree on any specific resistance test being useful for this. Obviously, adduction testing has to be present in adductor-related groin pain, and abdominal muscle testing being one of the factors more likely in inguinal-related groin pain. So we couldn't find a specific resistance test for pubic-related groin pain. We discussed hip-related groin pain briefly. We agreed, as I said, it's a common cause of groin pain. There seems to be no specific test that can give us a diagnosis of hip-related groin pain. What we know from the literature about tests for hip-related groin pain is that they have a good sensitivity and a poor specificity. What does that mean for us as clinicians? If I perform range of motion testing, the Faber test, or the figure 4 test as it's called, and the Fadia test or hip impingement test, if they're all pain-free, I can be confident that the hip is much less likely as a source of the groin pain. If they're positive, it doesn't necessarily mean that that pain is coming from the hip. We agreed when there's a clinical suspicion of hip-related groin pain that you should, as a clinician, treat or investigate that as you feel appropriate. That was a bit outside the scope of our day. The other causes, that's always an extremely long list, and rather than just presenting them to you one by one, it's all in the handout folder. We agreed on the contents of this table as being other causes of groin pain, some not to be missed, some common other causes. We also agreed to recommend certain terms to be avoided: tendinitis, tendinopathy, osteitis pubis, sportsman's groin, and sportsman's hernia. We felt that the continued use of these terms could not be recommended. And I was really pleasantly surprised by this, because it meant a lot of people who were on the consensus meeting panel had to actually give up terms that we had used for many years ourselves. So it was a real good congenial day where people were prepared to give up some of the old terminology for good. So time to say goodbye. So we've got now consensus on a clinically based system that defines specific clinical entities being adductor, inguinal, iliopsoas, and pubic-related groin pain. And then coming back to the cases, case 1 we would then call and classify as being adductor-related groin pain, and case 2 as being inguinal-related groin pain. Thanks very much.